Good morning, everyone. I am going to present my topic Submental Artery Flap, a personal choice in various defects in head neck region. There are plethora of choices exist for reconstruction in head neck region. Though free flaps are the method of choice, but in chosen cases, submental artery flap is a valid alternative. Submental artery flap is versatile and reliable. The main advantage of this flap is primary closure of the donor side defect without generating major functional or aesthetic defect. It offers excellent tissue pliability and color match. There is possibility of restoring pilosity in male patients. It is ideal for lower two-third facial defects in elderly male patients. It can be used for reconstruction of the ear, tongue, floor of the mouth, lower lip, etc. Now coming to aim and objective of our study. The aim of the study is to check flap reach in various locations of the head neck region. When raised in the standard technique, if the flap is reliable or not, to assess oncological safety and different extended applications, and to study anatomical variations of the perforators of the submental artery and its relationship to the digastric muscles. Now coming to the inclusion criteria. Tumors and defects present in the lower two-thirds of the face. Defect is non-composite in nature. Fitness or consent for free flap options were not given. Patients with clinical or radiological evidence of level 1 metastatic disease and positive lymph node are excluded from this study. Now coming to the material and method. It is a prospective observational study conducted at our tertiary care center from 2022 to 2025. 12 patients selected based on reconstruction need, complications, aesthetic outcome, and the oncological results, as well as the late outcomes of the submental flap during the follow-up of the patients were included in this study. Minimum follow-up period was 7 months. Now coming to the surgical anatomy. When we are telling about the surgical anatomy of the submental flap, first we know about the submental artery anatomy. It is the largest branch of the facial artery, luminal diameter 1.7 mm. It arises 2.75 cm away from the origin of the facial artery, and these artery runs deep to the digastric muscles in majority and cells perforated to the overlying skin and runs in the groove medial to the submandibular gland, bounded medially by the mylohyoid and above by the border of the mandible. It has various branches. It gives branches to the submandibular gland, various muscles, fatty layer. It has 1 to 4 cutaneous perforators that anastomosing contralaterally to the submental artery. And another important structure is submental vein, which drains into the facial vein, and that ultimately drains into the internal jugular vein through a variable branch, which is commonly located in the lower pole of the parotid gland, almost 90%. This communicating branch should be dissected carefully. In our study, we ligated the facial vein proximally to the communicating branch, and it allows 5 cm distal mobilizations of the submental artery flap, and this is called YV lengthening. Now coming to the technique summary, we raised the flap before limb adenectomy, and we dissected carefully to avoid the marginal mandibular nerve damage. YV lengthening used to extend the pedicle reach. We also used digastric muscles and mylohyoid muscles with this flap, and also used contralateral submental pedicles with this flap to increase the reach of the flap. These are the case illustrations where we used the submental artery flap. Now coming to the pictorial presentations, these patients presented with the intraepithelial neoplasia of the tongue, and we did wide local excision, and the defect was made 9 into 6 cm, and it is covered with submental artery flap. Next, this patient presented with invasive tongue carcinoma, which is confined to the lateral half of the tongue, and we used submental artery flap to cover the defect. Here we did wide local excision and MRMD. This patient presents with non-healing ulcer over the retromolar trigon, and this retromolar trigon is constructed with submental artery flap. Now coming to this patient presented with the non-healing ulcer after excision of the plunging ranula. And here we did the wound exploration. We excised the remnant tissue and the defect covered with submental artery flap. Here we used digastric muscles with this flap. This patient presented with recurrent MDCC field cancer. Here we used submental artery flap as a locoregional flap. Now coming to the ear framework, here this patient presented with the microtia. In the second stage of the otoplasty, we use submental artery flap to cover this ear. And this patient presented with angle of the mouth BCC, and here we did wide local excision and reconstruction done with submental artery flap. Now coming to results. We have 12 patients, among them 8 male patients and 4 female patients. Age group ranging from 5 to 50 years. The site of reconstruction, tongue reconstructed 4, angle of mouth 3, angle of jaw 1, floor of mouth 2, retromolar trigon 1 and ear 1. And indications, non-malignant cases we did 33.33%, non-invasive 44.44% and invasive malignant 22.23%. Here, when we did the submental artery flap, we found submental artery deep to digastric muscles in 75% cases and superficial in 25% cases. Now coming to the complications. There was one complete flap loss due to ischemia and one partial flap loss due to venous congestions. And these situations managed by debridement and secondary wound healing. We also see some minor complications, that is 2 delayed wound healing, 1 bulky flap and 1 slurring of speech. But these minor complications does not affect the final result. The follow-up period was 7 to 27 months. Now coming to discussions, submental artery flap is reliable, safe in experienced as well as resident science. It is comparable to free flap in cosmesis and function. Marginal mandibular nerve can be safely preserved if we improve the dissection, and it should be done in suprafacial level. Advantage of submental artery flap, it is thin and pliable, shorter operative time, good aesthetic results and low donor site morbidity. Now coming to our other concern, that is oncological safety. There is we always think that there is potential transfer of occult nodal disease. So we did a follow-up, but no recurrence is seen in follow-up. But during selection, we should select the node negative patients. Now coming to my last slide, that is take-home message. When mastered and indicated, submental artery flap is a valid alternative to free flap. It is ideal for elderly, high ASA risk patients and those who are not giving consent for free flap. It is reliable, versatile and cost effective. These are my references. Thank you. Thank you for my time.